All right, everyone, I'm back. This is chapter 21, drug therapy for asthma and other respiratory problems. That starts on page 340. All right, so basically, we just go over some basic stuff. We know asthma. A lot of time with asthma, patients are going to complain of wheezing, increased cough. It is reversible. Breathing is less effective when they do have it. They can have decrease in their O2 saturations, as well as their carbon dioxide levels can increase. And if it isn't taken care of, it can lead to death. So we do have to watch our stuff when it comes with asthma. Now, when we talk about COPD, that's something that will never go away. You cannot reverse COPD. You already have damage to the alveoli, and you're constantly producing mucus. So that is something that is going to be a long-term effect. Now, when we talk about like peak expiratory rate flow, or the PERF, this is a measurement of the airway function. It's how well a patient can blow out a breath. It will tell if the airway is narrowed. It does get the amount that you blow out depends on your age, size, and gender. If it's narrowed, you will have a decreased PERF of 15 to 20%. And if you are out of airway, it's going to be less than 50%. But like I said, it is measured according to age, size, and gender. And you'll learn that about in lab, about the peak expiratory rate flow. So those are some little basic things. Now we're going to talk about the types of drugs for asthma and COPD. Now, asthma patients, you need to make sure with asthma patients that they have something called a rescue drug, which is a reliever drug during an asthma attack. Okay, so when they're having an active asthma attack, they need a rescue drug or a reliever drug. Okay, they also have daily drugs or preventive, which are controller drugs that will prevent the asthma attack from occurring again. Okay, so if they're on an inhaler on a daily basis and they need to take it daily, that would be a prevention or a controller drug. Now, if they're having an active asthma attack, that is called a rescue drug or a reliever drug. Okay, so know the difference between those two. A lot of times with our asthma patients, they will use bronchodilators to open up those bronchioles, and they also use anti-inflammatory drugs to help with the inflammation that's occurring. So that's with our asthma patients. So, but you need to know the rescue drug and reliever, preventive is controller. Now with our COPD patients, same treatment as the asthma patients, but different doses. Both of them can use bronchodilators, both of them will use anti-inflammatories, and both can use mucolytics. So those are some things that we are talking about. Now, when we're talking about bronchodilators, these ones are the ones that are going to relax the smooth muscle in the airway. These ones do not help inflammation. It's only going to help relax the smooth muscle and open up the bronchioles. Sometimes there are a combination of two of them, the following. You can have beta-2 adrenergic agonist, which is a short-acting inhaler as well as a long-acting inhaler. You can have cholinergic antagonist, and you can have xanthians, which are rarely used because of the bad systemic effects that occur. So they rarely do not use those much. Now, when we talk about the beta-2 adrenergic agonist, these act like adrenaline in the system. It does cause relaxation of the smooth muscle, which is going to help with the breathing. Short-acting, you have the rapid, but they're going to be short-term relief. These ones are called the rescue drugs. These are the ones when you're having the attack you're going to use. And then, of course, there's you inhale it into the lungs. So those are the short-acting of the beta-2 adrenergic agonist. Now, the long-acting ones prevent an asthma attack from happening. So they're preventive ones. These are the ones you're going to take on a daily basis, even when you're feeling great and you're having no asthma symptoms, you're going to take these because it's going to keep the asthma attacks from occurring. So it's preventing the asthma attack. The effects are going to last longer. They're not good for acute episodes of asthma. So if you're having an asthma attack, your long-acting inhaler is not going to help. It's just going to cause more problems because it's not going to be working quickly and rapidly. It's not good for, like I said, the acute, but you can take it daily for COPD as a controller drug also. So on page 344, in our books are all the different types of inhalers, the bronchodilators. Now, as you can see, the short-acting beta 2 agonist, those ones you're going to take as needed basis. They're not the ones you're going to take on a daily turn. Those are as needed. So albuterol is a big one. Levoalbuterol, those are the two big ones that we use out there. So albuterol, when you see that, majority of the time, just remember when you see albuterol, those are short acting. Now, when we're talking about the long acting ones, these are the ones you're going to take on a daily basis. And like I said, salmeterol or Ceravent, that is probably the biggest one that we use out there. But otherwise, you're going to see that most acting. And they're going to take that on a daily basis, even when they're feeling better. So those are the beta 2 adrenergic agonist ones, the long and short acting. So the short as needed, those are the, the ones that we want to take, the rescue drugs. And then of course the long acting is going to be the preventive drugs. Now, when we talk about the cholinergic antagonist, and that's the one at the bottom, the atropium and tiotropium, the Spiriva. These ones, they will cause bronchodilator. They will help decrease secretions. They are controller drugs, so they are to be taken daily. So if they do have an attack, then they're going to take a short-acting beta-2 adrenergic agonist to help with that. But the cholinergic antagonists, those are the ones that are going to be taken on a daily basis to help decrease secretions and cause bronchodilation. Now, the xanthians, I told you, many side effects. We rarely use them, so we're not going to talk too much about them because they're not much, since we don't use too much of them. So, but no, they are out there. But let's talk about the side effects of bronchodilators. And you can see that on page 345. They will cause rapid heart rate. Biggest thing. That's why the majority of the time when they come in the emergency room and we're doing bronchodilators, we will put them on a monitor so we can watch their heart rate. If they have a high heart rate, then this is not the drug of choice to give them, because what it's going to do is just cause more increase in heart rate. We have to watch very closely. But that is one of the side effects. It will cause tachycardia. It can cause hypertension, so we do need to monitor their blood pressure. This will make them nervous and very jittery. They can have tremors. A problem sleeping, it kind of like hypes them up. But a big thing with them, it will dry their mouth and throat, and it will make things taste bad in the mouth. So that is something that we do have to watch. But they do have a lot of problems sleeping with these medications. So those are going to be the common side effects of your bronchodilators. Now, when you're talking about the cholinergic antagonist, their side effects, the big thing is these ones will reach the bloodstream. And when it reaches the bloodstream, it's going to cause a lot of drying effects. Okay, these meds cause a lot of drying effects. So I like how they say on the top of 345 in that memory jogger, can't see, can't spit, can't pee, can't poop. Go figure. But it does cause urinary retention. Blurred vision, and we know if anything causes blurred vision, we're concerned about our people who have glaucoma, because it can affect their intraocular pressure and cause them to go blind. So that's a big issue. Eye pain, nausea, and headache. So it does have some drying effects. So those are the side effects for the cholinergic antagonists. Now, adverse effects for these drugs: allergic reaction. You can have rashes, you can have chest pain, you can have lightheadedness after using the inhaler. If you use these meds a lot, it will go into your bloodstream and cause a lot of issues, can cause your blood vessels to constrict in the heart, which will lead to chest pain and actually can lead to a heart attack. So those are some things that we are concerned about, because these will reach that bloodstream. That's why we tell them, if you're using your inhaler too much, then you need to talk to your doctor and see what you can do under control. So what do we do before we give these meds? We're going to teach the patient how to use an inhaler and a spacer, and that is on page 346. And remember, know the different ways of using it. Know how to use an aerosol inhaler with a spacer, how to use it without a spacer, and very important, the dry powder. The importance of making sure that it stays dry, that we don't wet it or anything like that, or put it in a moist place. We want to keep that powder dry, and how to use the inhalers and that. So you need to know that, because you never know when that will be on the test. Also, another very important thing to do is listen to the lungs before you give the medication. Do they have wheezing? Do they have crackles? Because what's going to happen is after you give it, you want to recheck to make sure that the medication was effective or not. So after, like I said, we're going to check that breathing, make sure that the med worked. We're going to listen to the lungs. We're going to check the respiratory rate, the heart rate, especially 15 minutes. It can have systemic effects. So that's why we want to make sure we monitor the heart rate. Blood pressure also in 15 minutes can change. We're checking the pulse ox, and we want to make sure we check the peak flows that they have had an increase of 15%. So that's why we check things before and after we give the medication, the reasoning. Always ask if they're having chest pain, and if they do have chest pain, to report that as soon as possible. We are going to report if they have really high heart rates or tachycardia, as well as increased blood pressure, because we know that can occur. That's one of the side effects that can happen. If they receive 2 or more inhalers, always give the bronchodilator first. Bronchodilator first. Wait at least 5 minutes before you give the next med. So between inhalers, 5 minutes. Always give a bronchodilator first to open up those bronchioles, and then always give the next medication after to make sure that the medication gets in. So very important, bronchodilator first, wait 5 minutes, and then give the next inhaler that they need. Teach our patients to use as directed. Do not use it more. If you're using it more, there's an issue. Carry your short-acting inhaler like albuterol at all times, and make sure that you have enough of the medication. You'd be amazed how many people come in the emergency room and said, "Oh, I ran out of my inhaler." Well, when did you run out of it? Oh, like 5 days ago. That's not an excuse. You should always make sure that you have enough of your inhaler, especially if you use it frequently. Make sure using the short-acting inhaler too much is a problem, like I said, and we need to talk to the doctor to adjust the other medications or to see what else they can do, and find out what the cause is and why you're having those issues. Long-acting bronchodilators take as prescribed, even if you don't have any asthma symptoms, to make sure we prevent an attack from occurring. Don't use as a rescue inhaler. Long-acting inhalers can make attacks worse or can even cause death. That's why you cannot use them, because they're for long-term use, not for short. Now, the pediatric population under 4 years old, they should use the nebulizers, the nebulizer machine, to give the medications, because it's easier just to put the smoke in front and so they can breathe it in. And with the beta-2 adrenergic agonist for the pediatric population, oh my goodness, boy, it will definitely cause difficulty sleeping, especially if you give it around bedtime. These kids will be hyper. So it's not good to give to kids. So, close to bedtime, because expect them not to. So adjust their times appropriately that works around them. Now, the older population, more side effects relating to cardiac and nervous systems. We do need to check their heart rates before and after the use of these meds, and report if they get any tremors or have problems sleeping. If they develop chest pain at all, emergency room ASAP. Bad part is some of the dry powder, like the Spiriva on that. The bad issues with that, with our older population, is hard time loading that pill into the thing and then getting it. So sometimes they may need a new medication ordered, or someone can help them load up that powder form, because it comes in a capsule and it goes in a machine, and then when you break it, you inhale that powder. And you have to make sure when you inhale that powder, you take a big deep breath in, because you're inhaling powder. You don't want to blow into it, because you're going to cause moisture, and a lot of that powder is going to get stuck inside your inhaler. So that's why it's very important to teach our individuals about the usage of the inhaler. When they get powder, they can't get that inhaler wet, because powder will get gunked up in there. So those are some of the inhalers we're going to be talking about. Now, when we're talking about anti-inflammatory drugs like our corticosteroids, and we've talked about corticosteroids many times, and we know with steroids, those decrease the inflammation or swelling of the mucous membranes. They're not rescue inhalers, because, remember, corticosteroids can come in an inhaler. A lot of times people don't realize that they are steroids. So they're not rescue inhalers. They're not going to help you if you're having an acute asthma attack, but they are going to help control the disease process, the lung problems. So they are controller drugs. And on page 347 and 348 are some of our common anti-inflammatory drugs that we use, okay? And just depending, we have the inhaled corticosteroids, and I've given every single one of these. Let me check the second page here. Just usually the first page is probably the most ones that I've given. The ones on the first page, those are probably the ones that I've seen the most of. They do have bad side effects that occur with them, and that is on page 348. They can cause coughing, okay? They can cause a bad taste, dry mouth. It can increase your risk for oral infections. So a lot of times, people who take these anti-inflammatory drugs, these corticosteroids, it will actually cause thrush. So they can get candida infection or fungus on their mouth. That's why a lot of times important with these medications to prevent that good oral hygiene. When they do the inhaler, they swish and spit. You know, they do good oral and they swish and spit out so medication doesn't get stuck in their mouth. Another thing we need to watch for is blood glucose levels. When we take any type of anti-inflammatory drugs, inhale them, they have the risk of making blood glucose levels go up in our diabetics. So we do need to monitor their blood sugar, because a lot of times people that come in who are diabetics wondering why their blood sugar's out of control. Well, you're starting you on some steroids. You're inhaling them and it's causing your blood sugar to go up. So that's what we're going to be watching for. Now, adverse effects, it will irritate your tissue, which can lead to coughing or bronchospasms, which are not good. So that's why it's very important to use as directed. Low risk of adverse effects. Don't use as directed and use a lot. And if you use a lot, it can enter the bloodstream and cause that adrenal gland suppression that we talked about. And that's a bad thing. We talked about that back in our corticosteroid chapter, because they will go into the bloodstream if you constantly use these a long time. You know, keep using, oh, I don't feel good, another puff. Oh, I don't feel good, another puff. That's why it's important to tell them to take it as directed. So before we give these meds, we're always going to check the mouth for infection. We're going to teach the patient how to use the medication. Remember, if there's 2 or more meds, we always give the bronchodilator first. Then we're going to wait 5 minutes and then give the anti-inflammatory. Okay, but we wait 5 minutes in between. If we don't have to give the bronchodilator, then we just give the anti-inflammatory. After we give the med, we always rinse our mouth with water or mouthwash. This will help prevent that nasty taste that occurs with these, as well as dryness. We're going to teach the patient that the anti-inflammatory drugs alone can cause death in asthma patients because it doesn't cause vasodilatation. We're also going to make sure we tell them use 5 minutes after you give a bronchodilator. If you have a bronchodilator, be taken first, take that, then wait 5 minutes, then give the anti-inflammatory. We're going to tell them take even if they're not having problems breathing, because it's a prevention of an attack, and then it will help decrease inflammation in our asthma patients and our COPD patients. It can cause oral and respiratory infections, so we have to watch with that. We already talked about rinsing our mouth to get rid of that bad taste and dry mouth. And we're checking our mouth daily for redness or any white patches, especially for sores, because my friend she takes a steroid inhaler, and she actually got sores throughout her mouth, very painful. So she had to do a lot of oral care and get some medication for that. And also make sure you use very good oral hygiene. So that's information that, kind of important to teach our patients about these inhalers, the anti-inflammatories. Now, we do have combination inhalers, and that would have the bronchodilator as well as the anti-inflammatory drug. And there's a few. There's Advair, there's Symbicort, Brio, Dulera, and Anora ellipta. A lot of these, some are like the Dulera, they use more for asthma than anything else. And the Advair, Symbicort, Brio, and Anora ellipta, those are more for your COPD patients. But I have seen them used for asthma, but you'll see Dulera used more for asthma than anything else. It's the only approved one for asthma. But those are combination inhalers that have both bronchodilator as well as the anti-inflammatory drug. So if they are prescribed one of those, we have to teach them about both the dilators and the inflammatory. side effects and adverse effects, and what they should do and what they should not do and what they should look for. Now, when we talk about mucolytics, our COPD patients are prescribed these meds frequently. They help decrease the thickness of their mucus that they're producing in the airway. We can use them on the asthma patients only if they're having coughing up any secretions or have increased secretions. But the main ones that we use is guaifenesin, which is Mucinex, that little green glob that you see on the TV. I'm always following people around. Mucinex, that's what it is. Guaifenesin, which is Mucinex. Now, another thing that we use is acetylcysteine, which is Mucimist, and this is used for COPD, and it helps with mucus. It is put in a nebulizer, and they inhale it. Remember, this is also the antidote for Tylenol overdose. Remember when I passed around that nice smelling vial that smelled like rotting eggs? That is what we're doing. So imagine having to breathe that stinky stuff in the air. But acetylcysteine or Mucimist is also used for COPD. It's a mucolytic drug. Now, when we talk about pulmonary hypertension, these are other respiratory disorders, but pulmonary artery hypertension is a big thing. And there are many types of drugs that we can use to work on pulmonary artery hypertension. We can use vitamin K antagonists like warfarin. We can use prostacyclin agents, endothelin receptor antagonists, phosphodiesterase inhibitors, guanylate cyclase stimulators. All these meds will help improve the blood flow through the lungs, reduce the pulmonary pressure, and reduce breathlessness, and hopefully improve cardiac output for the patient, and that's what we want. But they have side effects that go with them. And like I said, on page 350 and 351, you can see the different types of drugs that they have. And I'm not quite sure. I don't think I've given any of these. I've done IV ones, but I can't. It's been like many, many moons, and I'm not quite sure if these were the ones that I used on them because it's been a while since I've had to take care of any pulmonary hypertensive patient. Usually, when we get them up to the intensive care unit, and they start all this stuff. But they do have nasty side effects. Our prostacyclin agents and our endothelin receptor agonists can cause headaches, decreased blood pressure, and flushing. Less common would be nausea and vomiting. So those are some of the side effects, and those are on page 351. Adverse effects, they can cause bleeding, increased liver enzymes, bone marrow suppression. So we know if there's bone marrow suppression, that's puts you at risk for what? Decreased white blood cells, which is infection, decreased red blood cells, which is going to be anemia, and decreased platelets, which is going to be bleeding issues. So those are some things that we have to look for. So anytime that we hear bone marrow suppression, that's what we're going to listen to. So before we give these meds, always check a blood pressure because the meds will cause hypotension. That is one of the side effects. Always get a baseline vital sign, heart rate, cardiac status. We need all those vital signs. Don't crush or split these pills. They cannot be crushed or split. They do cause birth defects, so definitely use birth control, and you don't want to give until you give a pregnancy test. They will cause big time problems, so we do need to monitor for that. After we give these meds, the best way to check if it's effective is by doing something called an ABG, which is an arterial blood gas. And that gives us what the patient is doing. We take a needle and we stick it into an artery and we pull blood from that to see how effective the patient is breathing, if they're getting enough oxygen, checking their pH, all that good stuff. So that is the best way to see if the drug is effectively working. We're going to monitor their vital signs every 4 hours. We're going to check bleeding labs, so we're going to do an INR. We're going to do this before we give the med and after, especially if we're on those prostacyclic agents. And we're going to report if the INR is greater than 3. We're checking the red blood cells and also white blood cells and platelets because we know that these meds do cause bone marrow suppression, so we want to watch for that. Liver enzymes we need to check because we know that it does affect the liver. That's one of the adverse effects. So we're going to be checking our liver enzymes, and we need to report if they're having any jaundice, if they're having that right upper quadrant pain, of course, the light stools and the dark urine. If we're giving IV, it's very sterile technique. We need to use a sterile line for it. And we must teach our patients about these meds. We want to make sure we tell them if they're taking these medications home IV, you do not stop the med, not at all, not even for a minute. It will increase your risk for death, and no other meds can be given in that line. So it is only, that line is for that medication. It is not used for anything else. We have to only use it for that one. And if they have any problems with that IV, if there's any issues, they need to go to the emergency room ASAP to get a new line started, because if not, they're going to die. Their blood pressures are going to go sky high and they're going to die. So we need to make sure that we keep the line sterile only for that drug, and that the line is working appropriately. If they're having any issues, they have to be seen ASAP. So they cannot stop their SMED if given IV. If they need to take pills, make sure they take it on time and not to skip or delay the dose. Always make sure you have enough pills, because otherwise that's going to cause a lot of problems. Like I said, if you go home with the IV, you need to be taught how to self-administer the medication by sterile technique, and to go to the emergency room if you have any increased shortness of breath, chest pain, swelling of the feet or legs, or sudden weight gain. And any problems with the IV, and I'm going to say it again, any problems with the IV, get to the emergency room to get a new IV started. Never split or crush these pills. Like I said, you need to use contraceptives, especially if you're on the endothelial receptor ones. Report any liver problems and liver tests we need to check. We need to check liver function tests, and we need to check the blood count because of the bone marrow suppression. So blood work is going to be very important also. So that's pulmonary artery hypertension in a little nutshell. Now the last thing is pulmonary fibrosis. This is a restrictive lung disease. Normal tissue becomes very fibrotic. You can see in older adults who smoke or exposed to irritants that they inhaled throughout their life, or some type of drug exposure. You see people working in the mines, working with asbestos. All that stuff can cause this pulmonary fibrosis. It's progressive with few remission periods. Usually once diagnosed, they say that you have a survival rate of about 5 years, but our treatment is to try to slow the progression. So they will use a lot of corticosteroids to prevent the inflammation and all that, and also immunosuppressants to suppress the body from attacking. So that's pulmonary respiratory issues. So that is the end of chapter 21. So hopefully any questions, you know, guys, what to do. And I will be back again with another chapter.